Hey, good morning, everyone. Let me know if you can hear me. Hey. All right, yes. We're nearing the end here. 2 more lectures for farm. Cool. And thank you for joining me early this morning. Good morning. You all had a good weekend. Howdy indeed. Say. Starting in a couple minutes, and then post your questions up in the chat or in the sticky board, and then whatever we don't finish today, we'll do next time, and then we'll have the review right after. I think be on Wednesday. That's tomorrow. All right. I gotta get that Kahoot ready for you guys. Yeah, thank you. It was fun. It's pretty chill, just hanging around the house. Not a whole lot to do. Just my mortality breathing down my neck, reminding me that yet again I've circled the sun. A little bit. It might be the midlife one, I'm not sure. Maybe past midlife, who can say? Yeah, I think we're just getting some costumes. I don't think we're actually doing anything, just kind of goofing around the house. I don't know if my wife has settled on anything yet, so we'll find out. I think my older one is into being a superhero. That's good morning, all. Thank you again for joining me. Right here in just a moment. You know how traffic can be this early in the morning. Be difficult to step over your dirty clothes and animals, perhaps. Get to the computer. Feel bad. I don't know if I should respond to every single individual good morning, because otherwise I feel like that would be kind of silly. Then I want people to feel left out. Let's just be rude and I'll say good morning to anyone, maybe. All right, but it's 8 o'clock. Let us begin. All right. So thank you all for joining me again. So you got about half the class in here, which is pretty good, right at 8 a.m. But so we have our last section for Farm 1. Congratulations, you're almost there. After Wednesday, you'll be done with this class. I guess next Monday, technically, but you're rounding the corner, fortunately. So let's talk about oncology. This is something where, again, if I did this every single day, day in and day out, I could probably give you more, like, really in-depth and like specific answers on things. But again, it's something I do deal with on a pretty consistent basis. We working in the pharmacy. You know, I still get to deal with a lot of patients who are getting chemotherapy, you know, verifying these meds, processing them, and all of that. So I do see quite a fair bit of it, certainly more than I'd see like something like derm, for instance. But if you have specific questions, you know, I may not have all the answers, but we can at least find out and look at some stuff if we need to. Generally speaking, because cancer is such a broad topic and there's so many different varieties and so many different ways to treat it, I don't know that necessarily I'm going to be asking you which one of these drugs treats leukemia, for instance, right? So indications are not going to be quite so important here. More specifically, what I'll be asking are going to be things like, you know, what are the mechanisms of these drugs? What are the important drug interactions? If there is a drug with an antidote, kind of similar to what we saw with the hematology drugs, like our anticoagulants. If there's an antidote, you should probably know that, because that's going to be important to limit a lot of the, or some of the toxicity you'll see with these drugs, of which there are many. I don't particularly like chemotherapy drugs because I don't like to poison people, and that's kind of what we're doing on purpose, and we'll see some of that become more clear as we go through this. But without further ado, you know, what is cancer? Well, basically it's this, you know, altered cell growth. It's basically these cells that normally would have some sort of trigger telling them, hey, to stop undergoing mitosis, but they lose that. So it could be issues that have too much growth factors, right? So for instance, if you're having too much estrogen telling breast tissue to grow, right? It may not even be too much estrogen. It could be a normal amount. It could be the cells are just more sensitive to them. You see things like, you know, this P53 gene that is normally responsible for telling cells that it should undergo apoptosis, right? The actual cell program, cell death. You lose that, then the cells don't know to kill themselves off, right? And they also lose something called contact inhibition, which is normally where cells are kind of crowded in with one another. They kind of tell to say, I'm crowded in here, I don't probably need to grow any further, and they can lose that. So a lot of different processes here that have gone wrong, so to speak, in order to lead to these cells kind of growing ad infinitum, right? So we don't always know the full etiology for cancers, right? But certainly there's this idea of carcinogenesis that undergoes several stages here. So for instance, you have like an initial step here, this initiation step of where maybe you have exposure to a particular carcinogen, right? Maybe it's like, you know, cigarette smoke or something. And then getting into genetic alterations, all kinds of things that can do this. And then you get into a promotion, like, so what is actually causing these altered cells to continue to grow? So is it due to an environmental exposure, or maybe a particular drug that is stimulating this? And then they continue to progress along, and then that's where you can get into maybe more undifferentiated cells. We get into invasion into local tissues, that metastases that happen there. And there you go, and I got a full case of cancer. So again, I like to point out you know, different types of substances that can lead to cancer, especially if they're drug related, because I think it's important to know that, you know, while we have a lot of drugs that can treat cancer, actually a lot of them can cause cancer as well. And so it's good to know because that's something, you know, a patient would want to know, right, in terms of risk for them. So looking here, just a few examples. So things like anabolic steroids, right? We will talk about that in the endocrine section next semester. Those are particularly rough on the liver, and so you can actually see liver cancer can develop from that. Things like certain anti-estrogen products, we'll talk about tamoxifen briefly here, can lead to endometrial cancer for patients who still have a uterus, for instance. You know, lots of different things here, you know, so certainly we'll talk a lot about estrogens and whatnot next semester. I'll get into all of that, but a lot of drugs here can do this. Again, don't memorize this list specifically, but we'll talk about some more examples as they pop up later on. So a lot of known carcinogens for sure. Now again, I kind of like this picture because it shows some of the different steps here that go through and lead to some of these cancerous growths to actually develop here. So for instance, you know, evading things like growth suppressors and inducing angiogenesis. This is an important one too. We'll talk about the ability for cancer cells to grow. They have to have nutrients, they have to have oxygen and blood supply. And so angiogenesis is an important step of that. And so if you can inhibit that, for instance, then the cancer cells will die off because they don't have any nutrients to continue to grow, right? So these can be different steps along the pathway that leads to cancer that we can interrupt perhaps by introducing some of our medications here. So this is just something to kind of think about as we get into the drugs to see how they work and what they're actually going to be doing for us. Okay, And again, you kind of see the steps that occur here. For instance, hyperplasia can be kind of one of the initial steps you can sometimes see with cancer. This is very early and is not certainly, considered to be dangerous in a lot of cases, but you will tend to find as things progress that, you'll find that cells become more undifferentiated. You're going to find that they can then start to sort of change. And some of this may be protective responses here. So something called metaplasia. An example might be a callus or something. So if you kind of use your fingers for rough work, all of a sudden they get more, that skin there gets harder. That's a protective function. That's sort of normal there. The issue becomes when we start to get to dysplasia. We have like this loss of uniformity. You start to lose some of the architectural structure. Starts to get a little is a little off there. In some cases, this may be reversible, right? So again, we're not really at the danger zone quite yet. But if you have those consistent sort of exposures, either to an environmental factor, a known carcinogen, things like that, this is where problems can run up when you start to get to neoplasias here. And again, this is the uncoordinated growth I was referring to before, where you have things like decreased response to suppressor genes, like p53 is a kind of a common one that's known to help to trigger off apoptosis. You can still develop these immortalization processes where they lose like their telomerases, and so basically the DNA becomes functionally immortal. And then again, this is typically irreversible at this point. So this is where we're starting to see the actual cancer occur here, where we may want to step in early. However, we may not be able to detect it this early because it's clinically not really producing a lot of signs or symptoms here. And they talk about tumor cells as either being like benign or malignant, and a lot of it has to do with things like, well, how localized is it? Is it able to be easily excised from the patient with something like surgical removal, for instance? It's a lot more difficult to deal with something like leukemia than a solid tumor, because with leukemias, it's in the blood, it's everywhere. It's not really something you can deal with from a surgical standpoint versus, say more benign things, like say if it's localized just to the skin, you may be able to remove that and have much more success there. So very, very dependent on the type of cancer you're dealing with and a lot of other factors as well. So my concurrent viewers went down to 0. It's odd. I got 48. So anyway, it looks like everything's working on my end. So let me know if you guys get kicked out or something. So anyway, and again, there's different ways you can kind of go through and grade these tumors here. A lot of it has to do with how much the cells look like the sort of parent tissues, how much they have sort of mutated away from that. And again, if they're having this increased mitosis or continuing to grow and replicate and all this kind of stuff until we eventually get to metastases, the metastatic grade of cancer here. Again, I'm not going to ask you on a task, grade this tumor, for instance, but just giving you an idea of how we talk about these things, because that can influence how we go about in terms of treatment, right? So treatment for a grade 1 tumor may be very different than a grade 4, for instance. So here's where I want to get into some of the principles here when we're talking about the actual drugs themselves here. So in general, just one cancerous cell is enough to lead to future cancers, right? So the idea is here, you have to kill every single one of these tumor cells here. If you even miss one, there's a chance that it can continue to replicate, and then you're back into the problem you had in the first place, right? So basically, this is where we have a lot of these remissions of or recurrences of cancer that can happen down the road there. Now, you can find that different tumors will have different growth patterns. This is another important one here in terms of like, what is the fraction of cells that are actively growing? We're going to find that has an important feature in terms of how our medications are going to work. A lot of the drugs that we have work better on actively replicating cells than they do for cells that are kind of in a more dormant sort of state. And that'll be important when you talk about the different mechanisms here in a little bit. But also, are we dealing with a lot of the same type of cell, or is it something that's less differentiated? That may have an effect on the drugs being able to work there. And again, different tumors will have different growth rates. So something like colon cancer tends to be a lot slower growing than something like a leukemia. And again, that makes sense if you think about the cells that are being involved there. You're constantly producing new white blood cells, right? You may not necessarily be producing colon cells at the same sort of rate there. And so again, we'll see how the drugs interact with that. Localized versus disseminated growth. Is this something that you can deal with very localized radiation or surgery, or is this something that is disseminated and you're going to have to go with more systemic therapy, right? That's where we're going to get into more of our chemotherapy. That's going to be important here because a lot of those are systemically administered. And then the heterogeneity of the tumor. So how, is it just one type of cell you're dealing with, or is it multiple types of cells? Because not all drugs are going to be treating those equally. So there's another feature here called Gompertzian cell growth. If you ever hear that, basically it's the time it takes for a tumor to double itself. Tends to stay pretty consistent. So initially you're going to get really rapid growth of a tumor as the cells are able to sort of rapidly double at the same rate. But you will see at a certain point that things tend to flatten out. And this is typically where tumors are outgrowing their nutrient supply here. And so I'll show you the picture. And so you can kind of see this right here as if you look at the number of cancer cells on the y-axis here and time on the x, you can see that even when you're starting with a single cell, they start to double quite quickly here, right? And again, this is sort of a subclinical diagnosis at this point. The patient may not have any symptoms. You may not be able to catch it early unless you're doing like screenings or something like that. And then it continues to grow. And then eventually you're going to get to a point where it's going to flatten out here, right? And the point of that is that it outstrips its nutrient supply. You're going to find that it is maybe not getting enough blood flow to the area. A lot of those cells are not going to be actively replicating. And that has an important role to play in terms of how well a lot of our drugs are going to be working, because a lot of the drugs work better on actively replicating cells, okay? However, we're going to see that a lot of our, modalities of therapy are multimodal, right? We're going to be using multiple steps here. So surgery plus radiation plus chemotherapy in various ways in order to help us out, in order to kill as many of the cells as we can, right? So anyway, so when we're looking at this, it's important to consider too that even if you get something like 99.9% of cells killed with one sort of type of intervention, you're still going to have a decent number of cells that are left around here. So for instance, if you had your diagnosis right here and the patient underwent surgery and they had, say, a 3-log reduction of the cells that were there, even more so than that, you can still find there's a significant number of cells available here that can just continue growing again. So that's why it's difficult, because you may think, okay, it's a well-localized tumor. This is great. We're going to do surgery. Cut it out, right? Well, even if one cell is left behind, that's still a chance that cancer can return, and it's very difficult for a surgeon to look at the tissue and be like, okay, got all the cancer cells, they're all gone. Not really all that effective there. There's certain types of surgeries that may be more reasonable. So for instance, I think is it like the Mohs surgery? I think it's a form of skin cancer treatment where they can actually look at the borders and see if there's any cells. Again, I don't know much about it, but there may be some ways to do that. But again, it's not super common. Yeah, thank you, Isabel, for confirming that. I didn't know about that even until some of my previous grads were telling me about it. I thought it was pretty neat. Yeah, I like Mohs Shroot. He's one of my favorites too. But again, you can see here, 10 to the 6 number of cells. I mean, doesn't sound like a whole lot, or I mean, it's a big number, but it's still quite small. And again, that's plenty of cells left over to continue to grow and continue to establish that cancer again, right? So anyway, so when we're looking at treatment here, again, removal of the tumor, if possible, should be the first step. So that can either be with like surgery. So if it's a well-localized tumor, like say like a brain cancer, if it's localated is not a word, but if it's well localized to one area, that can be much easier to go in and actually cut that out. As I was saying, they dye and examine the tissue in office. If they don't have clear margins, they excise some more. Yeah, I thought that was pretty interesting. They were talking about how they had to continue like kind of cutting into various areas until they finally got all the cells gone, which is pretty odd. Or I mean, not odd, but it's pretty wild to hear. Maruk was saying, my dad had SCC and his right jaw and had it surgically removed, repeated radiation sessions after to ensure no cells were left over. Yes, that's a great point here, which you can see. So as I mentioned, like surgery is good for like different types of tissue you can get to relatively easily to cut out. Radiation is then going to be good for tumors where maybe you can't get to as easily from a surgical standpoint there. And then chemotherapy kind of gets everything else that's left over. You'll see there's some forms of localized chemotherapy, but a lot of times you're going to find that they're administered systemically to make sure you get any cells that have sort of been left over that may be circulating centrally, that may be left over in the margins there. So, and a lot of the chemotherapy targets rapidly dividing cells. We're going to see exactly why that is here in just a moment. So again, here's this idea of utilizing multiple rounds of different modes of therapy. So for instance, here, if you imagine this person got surgery to knock that cell down count pretty significantly, then you can have multiple rounds of chemotherapy in order to get further knockdown of all these cells here. Now you're like, well, why in the heck are you having to give all these different rounds here? Why not just give as much chemotherapy as you can just to get it down to 0? And we're going to see why that's not a good idea, because basically these drugs are poison, right? We're going to see that they are not great from a health perspective. They make you feel terrible. They kill off a lot of healthy cells in addition to cancer cells. So there's going to be a limit to how far we can push these patients. We'll see how that comes into play here in just a moment. So looking at in terms of drug exposure, obviously drug concentration, how long people are exposed to the drug, and how frequently they're getting it, all plays a role in terms of how effective the drugs are going to be. And it's really a point of trying to maximize the benefit versus the risk ratios here of the drugs, because they all have big risk associated with them, right? So I'm going to focus a lot on side effects of these medications here because they are numerous and patients need to know about them. And you can see really significant toxicities like myelosuppression. And from my standpoint, what I see mostly in the hospital is because, I kind of see it in two places where patients, for instance, they come into our infusion center and they actually get their chemotherapy there, but sometimes they have to come inpatient, either because they're getting more intensive chemotherapy regimens or they have developed, say, an infection, for instance, because a lot of these drugs induce myelosuppression, as we'll see here in just a little bit. And so they get secondary infections. And honestly, what I see frequently in the ICU, if these patients die, it's not from the cancer specifically, it's from the myelosuppression that we induced as a result of using the chemotherapy, right? They get a secondary bacterial infection that may lead to a fungal infection. It can be quite challenging to manage those patients there because we're going to hit their immune system so hard here. So typically what we do is we shoot for sort of high dose regimens that are intermittent, right? So we'll go and give them a big dose of medication, try to knock down as many cancer cells as we can, and then we give their body time to recover. And so we'll allow for the blood cells to recover, let their white count come back up. We frequently look at their neutrophil count. So if you ever hear like absolute neutrophil count, we frequently look at that. We look at their platelets because those are also rapidly dividing. And if you're too intensive with the chemotherapy, you may find that they can wipe out all of their immune cells, neutrophils specifically, and then they can be at increased risk for bleeding because they don't have enough platelets around. So we have to give them time to recover from that standpoint. And then we also want to think about the timing for maximum susceptibility. And so this is going to be important in terms of where the drug acts in the cell cycle, right? So we're going to talk about our PMAT here a little bit, going back into our mitosis and the cell cycle. So if you have your undergrad biology books available, that might be useful here. But basically, we want to try to get cells where they are most active within that growth curve, where they're actively undergoing replication of DNA, where they're actively undergoing mitosis. That's where the drugs are going to be most effective here. So going back and looking at your cell cycle here, we recall this where typically you have like your G0 phase. This is where most cells are kind of just chilling out, kind of doing their thing, not necessarily in an active growth phase. A lot of cancer cells are not going to be there, right? Because they are missing a lot of the signals that says, hey, go into your resting phase. They're going to be switching over, going to mostly into the G1 phase, where they're undergoing things like DNA replication, or getting like protein replication, stuff like that. S phase is where you're getting the majority of your DNA replication happening here. G2, and then finally mitosis, where the cells actually will actively double. And so if you can catch a lot of your cancer cells while they're in this cycle here, you're going to be able to get a better percentage kill, so to speak, in terms of getting rid of those cancerous cells. And so we're going to see some of these drugs are very cell cycle specific, meaning some of them work very well during the S phase. Others work specifically during mitosis, whereas we can have some that are cell cycle non-specific and they kind of work anywhere. And we'll see how that sort of plays a role in terms of our regimens here in a little bit. So, and you can go back here and look at all the different classes. We're going to talk about most of these here as we go through. So don't worry about these names here if you haven't seen them yet. We will cover these. As I mentioned, the cell cycle, I kind of talked about these points here. S phase is going to be a particularly important step that we're going to be targeting here. Mitosis itself can also be an important step. But any time where we have active protein production, DNA replication, mitosis happening, those are going to be great targets for drugs to be working at here, right? Again, the problem we're going to see in a lot of cases here is that drugs used for chemotherapy typically are not specific for tumor cells, right? They're going to be affecting any rapidly dividing cells just like they do cancerous cells. So if I have a leukemia that is actively replicating all these white cells here, and I give someone chemotherapy to try to get rid of those cells, they're going to be affecting other rapidly dividing cells too. So my skin can be affected. My mucous membranes can be affected. So the GI tract is particularly affected there. Hair cells can be affected. That's why you see alopecia as being a common side effect for many cancerous drugs, and it's probably like the most common thing that patients think about when they think about cancer treatment. That's all because those cells are actively dividing, and if you inhibit that by giving chemotherapy, it's generally not specific. You get a lot of collateral damage, I should say, in those cases there. Hopefully you're preventing casualties, but collateral damage is what we're terming as. So to go into that, when we're talking about the cell kinetic parameters, what we call the growth fraction is typically the proportion of cells that are actively dividing, right? So again, if you have a tumor that's quite large, that's sort of outstripped its nutrient supply, you'll have a relatively low growth fraction. That's where you get up in the upper part of that, the flat portion of that curve there that we looked at. Whereas if you are able to knock that down with surgery or something, then you can end up seeing a higher growth fraction there than actively dividing, right? Kaylee's asking, could skin ulcers be common with cancer patients? I don't necessarily see a lot of like external skin breakdown necessarily, but what I end up running into more frequently is going to be mucous membrane breakdown. So like things like stomatitis is quite common. A lot of diarrhea associated with this as well. They can have malabsorptive issues. They have a hard time swallowing in a lot of cases because they have these ulcers that can form there. So it's certainly stuff you see from a GI standpoint. And we'll talk more about the issues here we'll see in just a little bit. The S fraction is specifically referring to what percentage of the cells are actively in their S phase, or they're reproducing new DNA, and that can imply sort of the aggressiveness of the tumor. So a higher S fraction means more aggressive, and then getting into the doubling time is how much time it actually takes to double. It's pretty easy. And so if it's a short doubling time, then that indicates, again, a more aggressive tumor. They're going to be much more rapid in producing new cells and able to produce more of them that can spread out and cause metastases and all that bad stuff. So when we're looking at drugs here, typically we try to use combination therapy. And so you can kind of think about, like we were mentioning with anti-infective drugs, how sometimes you use combination therapy. This is what we're doing here, but instead of targeting bacterial cells, which are different enough where a lot of our anti-infectives don't really interact with them, here we're dealing with cancer cells that are meant to take out human cells. And so again, we're going to see that we can kind of think about the same sort of paradigm there. So we're going to find by using combination therapy, it helps to minimize resistance because our cancer cells, because they are rapidly dividing and potentially mutating, they can develop resistance just like bacteria do. And that helps to minimize some of the toxic effects as well. Maybe using lower doses of multiple drugs can help to mitigate some of those side effects there. Okay. There's also going to be a heavy role for adjuvant therapy that are either there to treat or minimize those toxic effects. So a big thing you think about with cancer treatment is going to be nausea vomiting. It's huge. Some drugs have almost 100% nausea vomiting reaction because your body is detecting it as poison and wants to get rid of it, right? So antiemetic drugs are very important here. Drugs used to help stimulate new blood cell production. So things like bone marrow growth stimulators are going to be used here to make sure that our patients can sort of replenish their immune system, so that way they're not at risk for secondary infections, right? So lots of things that go into chemo regimens that aren't specifically chemo drugs, as we'll see in a little bit. So with the timing of chemotherapy, typically you'll see that some drugs being cell cycle specific, they're only going to hit drugs or hit cells as they are in that particular stage there. And again, not all cancer cells are all hitting the same stage at the same time there. So in order to try to get as many of those cells as they enter a particular stage as possible, we could do things like continuous infusions. I've seen some patients get a 5-day long continuous infusion of a medication in order to make sure that as many of those cells as possible all hit the that particular phase, whether S phase or M phase, whatever the case may be there. For non-cell cycle specific drugs, you can kind of give them whenever. They will be effective at any point. So we'll look at some examples of that later on. Again, chemotherapy is given in cycles. So you may see, okay, they're on cycle 1 of this particular phase of a treatment. These are typically defined, often repeating schedules, and again, they allow for recovery. Sure, during that time, our cancer cells recovering as well. Yes, we're aware of that, but we can't keep giving chemotherapy to our patients because eventually they'll die off, and we want to keep them around. So again, the whole point is to hit the cancer cells hard, knock them down, give the body time to recover. The cancer cell counts are going to go up too, but you want to go ahead and try to get down and hit them again as you hit the next cycle there. Now, a lot of this is determined with clinical trials, and so this is a big thing, especially in pediatrics. But most, at least where I deal with it most often, which is pediatrics, we try to get most patients onto some sort of clinical trial in order to find out, what's the best way to treat these patients, because you can't really do a randomized controlled trial in the typical sense, because how do you can't give people cancer and then give them randomized treatments to see what they get. However, we try to make do with what we can, and so we may do trials where we enter patients as they get diagnosed, and we try to see what they're eligible for and do that. So if you ever hear about the Children's Oncology Group, that is something that we do quite frequently for a lot of our patients there. And again, it's never placebo controlled because you can't give someone with cancer no drug because we know that's unethical. But typically it's like modifying a regimen where they may get a different drug or a different dose of a drug in order to see what's most effective there. So here's an example of what we call a roadmap. A roadmap is a very important document in a patient's chart that helps us to know what drugs they're getting, how much they should get, how often they should get it, etc. We're going to find that people that work in oncology, they love their acronyms. I'm not going to ask you any specific acronyms, but if you hear me refer to some of these as by their acronym, that's where it comes from, is because it's just kind of the common vernacular there. So for instance, things like cyclophosphamide is CPM, or like cytarabine is ARA-C, MTX for methotrexate. But people in oncology and people in HIV treatment, they love their acronyms, and we'll see those examples later on. But regardless, this is an important thing here. So for instance, here you can tell what phase of the treatment that a patient is in, right? So it could be induction, could be consolidation. There's different phases associated with these things there. And then what type of treatment it is. So here you can see this is for acute lymphocytic leukemia. This is a particular trial where they got randomized to a certain arm of a trial. So either they're getting a particular type of dose or whatever the case may be. And so you can see here they tell you specifically what to be monitoring for, because we know all of these things here are going to be associated with some of the drugs we run into. So things like looking at their CBC with their differential and platelets, so we can look for neutrophil counts and things like that, right? We're looking at things like the patient's weight, because we know that patients tend to lose weight while in chemotherapy because they don't have much of an appetite and they don't eat as well as they might otherwise. Patients, obviously this is for a pediatric patient, so obviously their height is changing quite rapidly as well, which can be important if you need to do a dose change or something. So point being is you get all this stuff and you see all the drugs they're supposed to be getting, all the dosing and all of that, and then we follow the roadmap. So we see what day they're on. They either come into the infusion center, they come in inpatient or something like that, and then we give them the medication based off what they're getting here. So here's an example of a drug we would give as a continuous fusion over 5 or 4 days here, right? So we get this consistently every hour, roughly, so it's a continuous infusion over 4 days, basically, right? And then you repeat that 4 days later, right? This whole point is to give patients time to recover, and then you hit them again, right? Some drugs will be given consistently throughout the whole period there, so they get this mercaptopurine for 14 days. I think mercaptopurine is one of the drugs in your prescription assignments. Notice here too, intrathecal methotrexate, right? So instead of giving it IV, they're actually getting it into the spinal column itself to get any cancer cells that might be there. So different routes we can administer, especially in protected sites like the CNS. It's difficult to penetrate particularly. So again, not to have anything you memorize from this specifically, I just wanted to show an example of how we do these different regimens. You can kind of see this sort of cyclical sort of approach that we have with a lot of these things here. So there are other types of therapy though, and the nice thing about as time progresses, we develop more targeted therapy. So we have found ways, and particular for certain types of cancer, to be more specific to try and mitigate a lot of the toxicity, right? So if you kind of think about, something like our non-cell cycle specific drugs, like some of our alkylating agents, which I'll talk about in a little bit later on, they affect everything. So they affect healthy cells, cancer cells. They're pretty nasty from their side effect profile because they just affect everything, right? So it's kind of like using like a shotgun blast approach to getting rid of someone's cancer here. This is a much more refined, sort of very specific approach where if we can target certain things that may be overexpressed in certain types of cancer, you can help them mitigate toxicity to healthy cells because they just don't express these things here. So for instance, we can use different types of therapy that affect certain growth factors, right? So for instance, utilizing different antibodies that may neutralize growth factor receptors or the growth factor itself. We can utilize things like vaccines, for instance. So, HPV vaccine being utilized to prevent cervical cancer, primarily, things like that. Or we can try to give drugs that try to boost the immune system. So different places we can sort of introduce medications that may be more specific for cancer cells in order to try to mitigate toxicity to all the other healthy cells around them, okay? So it's very specific, though, to certain types of cancers, or may even be specific to certain mutations that the patient may express. Very specific, right? So in general, I'm going to be focusing on sort of the more old school, non-specific drugs. I will show you a few examples of these later on. Many of these are too numerous to go into here because a lot of them are so specific for certain types of cancers. It's a very niche sort of thing, so I'm not going to get into that. I want to cover the common stuff that you can run into, even if you're working, internal medicine, if you're working ER, if you're working anywhere else. You'll see these patients who are on these medications, and you want to know kind of what those implications are. And obviously, early treatment, early detection is going to be super important for these patients. So make sure they're getting the screenings that they're supposed to. If they need a pap smear, if they need a colonoscopy, whatever they need, make sure they're aware of that, doing self-checks, all that good stuff to make sure you catch it early. Because the earlier you catch it, the better your outcomes are going to be most often. Now, as I mentioned with toxicity, this is a major component here because, it's, again, I frequently see patients complaining about these side effects of these medications and not necessarily the actual cancer itself, right? Because a lot of times cancer may be, asymptomatic in some cases there, but the toxicity here, the drugs we're giving certainly are not asymptomatic. So as I mentioned, a lot of the drugs we use are non-specific between cancer cells and healthy cells. They affect anything that's rapidly dividing, whether it be bone marrow, causing significant myelosuppression. So you can see increased risk for infections there for sure. You can see that the platelets are affected. So you can certainly see that, bleeding is a risk there. And in fact, if you go back to this roadmap here, you can actually see, where's that? Okay, if you notice here right at the top here, notice they're talking about starting this when ANC is above 750 cells per microliter, platelets above this. Some of these can be cell count dependent, meaning that we have to have certain levels of cells before we can give them more drug because we don't want them to be so suppressed that they can't, clot off effectively. They can't, fight off any kind of infection there. As I mentioned with the GI tract, you're going to see a lot of oral and intestinal ulceration, which can have a huge effect on their nutrition. We'll see that alopecia can be common with some of these. And then as well, reproductive cells can be affected. So maybe you're seeing menstrual irregularities. Certainly, you don't want any of these patients to become pregnant while taking many of these chemotherapy drugs because what is a fetus other than a mass of rapidly dividing cells, right? So those can definitely be affected. So things like pregnancy tests are important for people who are of childbearing potential, right? So there's certainly a lot of ways that cancer cells can become resistant. So a lot of these are very similar to what you might see with bacteria, right? So they can have things like, decreased uptake of a drug. Maybe they downregulate some uptake transporters. Perhaps they mutate certain targets there. So this is something we'll see. It's probably not as quickly occurring as you might see with bacteria, but it's certainly something we consider there. And again, why we dose medications like we do, why we use combination drugs in order to help mitigate some of this resistance here. Okay. All right. So, and then two, like, what's our goal of therapy here, right? So are we looking for more curative treatment? Are we looking to actually get rid of the cancer entirely? Or is it more palliative treatment, right? Are we trying to make patients more comfortable and we're maybe more focusing on their quality of life versus the quantity of life, right? And this is going to be very dependent on the type of cancer you're dealing with, the type of patient you're dealing with, what their priorities are, etc. So again, just know that sometimes you're giving chemotherapy not to cure the patient, but maybe just to make things more comfortable for them as they head towards their unfortunate demise, right? So let's get into the specific drugs here. I've been kind of waxing poetic about all the ancillary stuff. Let's get into the nitty gritty here. Again, this is not an exhaustive list, although you might be exhausted by the end of this for sure. But these are the common things. These are things you're going to run into more frequently. And then towards the end, I'll start getting into more, newer drugs. I'll get into things that are more specific, just to give you some ideas of the type of kind of the direction that things are moving in. So if you're interested in this stuff, you can look more into it. I know not a lot of our people go into oncology, but some of you may. But certainly, no matter where you work, you're going to be running into cancerous growths, right? So whether you're in derm, whether you're in internal medicine, you're going to be running into this stuff. So you got to be aware of the drugs to know kind of what to expect when you see a patient coming in and say, hey, I just got a dose of doxorubicin. Okay, well, what does that mean for you? Could mean something, could mean nothing. So anyway, this is a handy page, I think, that's useful to kind of sort of pictorially give you an idea of what's going on with our different drugs here, kind of where they're working at, kind of what they're doing. We'll get into all these specifically, but you can refer back to this to give yourself sort of an idea of like where are these drugs working at, what are they doing specifically. So we'll get into that in more detail here. The first class I'll talk about here are called the antimetabolites. Am I cutting in and out for you guys? Yeah, for some reason it looks like I had a big drop in the concurrent viewers, but my end is looking okay. So, okay, that's good. Fantastic. Well, you probably always just backtrack it. So, it does look weird on my end though. I will say that for YouTube, it had like 2 little drops in the number of viewers, but whatever. Anyway, so first class I want to talk to is going to be the antimetabolites. And so basically these are going to be drugs that look very similar to the nucleotides that make up our DNA and RNA. So you think about things like cytosine and guanine and adenine and all that good stuff. These are going to be drugs that sort of look like those, but they are going to have some key differences that make it poisonous to these cancerous cells here. And so basically, a lot of times the body and our cells can't tell the difference between naturally occurring nucleotides and the actual drugs that we're giving here. And the whole point of them is that they are going to be disrupting the replication and cell division that occurs here. Because if you disrupt their ability to produce new DNA or new RNA, then you pretty much halt the ability for that cell to replicate itself, right? It can't undergo mitosis if there's no new DNA there. And so, as I mentioned, these are not selective for cancer cells, but they are going to be selective for rapidly dividing cells, okay? If it's a cell that is relatively stable and not undergoing active mitosis, then you're probably not going to see a whole lot of interactions there because they're not in a state where they're producing a lot of new DNA. A couple of different categories we're going to get into. We have our pyrimidine analogs and purine analogs, and then we'll have our folate antagonists here at the end. And again, some of these will look similar to other mechanisms we've seen before. For instance, with antiviral drugs, things like acyclovir kind of had the same mechanism as our purine and pyrimidine analogs we'll see here. First drug we'll get into is going to be cytarabine, frequently called Ara-C, if you ever hear that. And again, you can see how this sort of works. So if you look at cytidine here normally, or deoxycytidine that might be incorporated into your DNA, basically we just kind of move the hydroxyl group here, right? We just change its conformation, and all of a sudden, we get a pretty interesting sort of interaction that happens here. So even a simple change like this, and your cells can't tell the difference, right? They just incorporate it in and say, hey, this looks like cytosine, everything looks good. Or looks like cytidine to me, and so then it gets incorporated in. What happens though is it's going to become phosphorylated, and then it actually ends up inhibiting this DNA polymerase by basically working as a chain terminator, right? So I always thought that sounded like a pretty cool metal band name or something like that. But basically, by incorporating into the DNA, it cannot add any further nucleotides to that. So you can't elongate the DNA any further, and eventually this causes enough issues in terms of DNA damage that it will then trigger off apoptosis, right? Basically saying, hey, this DNA is too damaged, let's go ahead and kill off the cell, we'll go back and restart over with a new one, right? So again, I'm not going to ask you a lot of specifics about how these drugs are administered. There's a few examples where I will be very specific about that later on. And I'm not going to ask you specifics on the types of cancer these things treat. Okay, I'm not going to ask you, does this one get used for leukemia or something else? I just try to use it as context, right? So you guys can have an idea of what type of patients you may see on this drug here. The toxicities, though, are super important, and a lot of these may be consistent amongst the classes. Some of these may not be, as we'll see here. Some of these may be unique to specific groups here. So I'll make note of those when we run into them. So anyway, what are our toxicities here? Well, dose-limiting leukopenia and thrombocytopenia. This is going to be a common thing with a lot of these drugs here because these are rapidly dividing cells. If they're being inhibited from growing, then you're not going to have as many of those cells. So neutrophil count's going to go down, platelet count's going to go down too, and that's going to lead us to be very cautious before we give more of it if their counts have not recovered, right? So we talk about cell recovery in between rounds of chemotherapy there. Nausea, vomiting, mucositis is going to be something you commonly see amongst a lot of these drugs here. And then, so some unique things you might run into includes the cerebellar syndrome, and this is more seen with like really big doses of cytarabine, where they can end up developing dysarthria, nystagmus, and ataxia. And some of this may be related to other organ function as well. So for instance, these patients get a big dose of cytarabine, but they have poor renal function, they can't clear it, then they can develop some of this CNS toxicity seen here. And again, these are things that patients would be told to look for. The nurses that work in the infusion centers would be knowing to look for as well. They should be asking the patient about these things to make sure we're not going to run into issues here, because this may lead to discontinuation of the drug if it's severe enough in some cases there. You're also going to see conjunctivitis can be common for some of these drugs here, and so this is where either we can get away with things like steroid eye drops, so like fluoromethalone or something like that, or they will just use saline eye drops like balanced salt solution or something else to help prevent corneal abrasions and help with patient comfort. Another drug here is kind of similar to cytarabine, but if you notice here, instead of moving the hydroxyl group, they just go ahead and put 2 fluorines on the molecule itself. And so the mechanism is identical. It's just a matter of it being technically a different drug because the chemical structure is different. So this one is a gemcitabine or Gemzar. And again, it's going to be doing the same thing. It gets incorporated into the cancerous cell DNA, and it prevents any further elongation, right? So it's inhibiting DNA polymerase. You can also see here it's going to be affecting RNA production as well. And so again, because its mechanism is similar to cytarabine, the toxicities are actually going to be pretty similar as well, as we saw on the last slide here. Now, with some of these drugs, you can get kind of flu-like symptoms when they're being administered. This is sort of like a mild immune reaction you can see with that. So they may complain about low-grade fever, that gets kind of chills and maybe some arthralgias. Usually these can be managed with things like acetaminophen, right? So just kind of see some patients getting pre-treatment with things like acetaminophen, but they're generally pretty mild and limited to when they're actually getting the infusions there or shortly after. Next, we have our first pyrimidine analog. So this is 5-fluorouracil, or 5-FU. Again, don't take offense to that. But this one has a kind of an interesting sort of mechanism as compared to what we saw with our I'm sorry, this is all pyrimidine analog, so I apologize. This is a little bit different mechanism than what we saw with things like cytarabine. Capecitabine is another one that is very similar. It actually gets converted to 5-FU in the body here. And so this is actually a false pyrimidine, and what it does is it actually inhibits a enzyme called thymidylate synthase. I apologize for my mispronunciations here. It's very early in the morning, unfortunately. But basically, it inhibits thymidine formation. So instead of working specifically to get incorporated into the DNA, this actually works on the nucleotide formation process here. So 5-FU will come in here, inhibit the actual thymidine production, and then now you don't have any thymidine to get incorporated into the DNA. Sort of the same sort of process happens from there. It triggers off DNA damage and apoptosis and all of that. Here you can also find that the drugs will get incorporated to RNA, and that can actually inhibit its function as well. So kind of a little bit of a mechanism there. See in lots of types of leukemia most frequently. And again, the toxicity is going to be fairly similar to things like cytarabine. So dose-limiting leukopenia, mucositis, cerebellar syndrome. And sometimes what you'll see with some of these drugs is sort of a peripheral neuropathy. It's called hand-foot syndrome. And so again, typically you find the sort of the longest nerves being affected here, which is typically to your extremities. And so they may complain about neuropathic pain and their fingers and toes, and so it has that sort of hand-foot distribution. If you ever hear like a stocking glove distribution, kind of an outdated reference. I don't know too many people that wear stockings or gloves all that often, especially in Florida, but that is what we're kind of talking about there. And again, it may limit further use of that drug if they're complaining about these neuropathies, if they're not kind of getting better on their own. Okay, now we're switching gears to the purine analogs. Here we have 6-mercaptopurine and then thioguanine. Again, these are working pretty similar to what we saw with cytarabine. They're just basically preventing purine synthesis in terms of preventing adenine and guanine from actually being formed here. And they also get incorporated into the DNA and then will prevent DNA polymerase from actually being effective there, because again, they kind of work as a chain terminator. So very similar in mechanism. It's just that it's affecting purines instead of pyrimidines. That's the only big difference there. In terms of toxicities here, you do want to watch liver function tests. You'll probably be watching liver functions for a lot of these drugs here. And again, myelosuppression is going to be pretty ubiquitous amongst these drugs. Also, it's kind of interesting too is you can have some pharmacogenetic influences here. So again, this is mutations that the patient has on their own that may either change expression of certain enzymes. It can actually lead to worsened toxicity. Maybe they're not able to metabolize 6-MP as well, and then it sort of builds up and can lead to further myelosuppression. So some of these things you may actually do genetic testing on beforehand to make sure they don't have any of these enzymes being either not expressed enough or overexpressed, depending on the situation there. All right. And then finally, in our antimetabolite section here, we have our folate antagonists. And so these do exactly what it looks like. And these are kind of similar. If you weren't looking for an analog for these or this drug, you would probably consider this to be like Bactrim was for antibiotics, right? So remember how sulfamethoxazole and trimethoprim prevent utilization of folic acid in the bacterial cells. Well, methotrexate actually does the same thing here in cancerous cells. And if you look at the structures here between methotrexate and folic acid, you can see how they look pretty similar to one another in your mind. There are some key differences, though, that make methotrexate effective for what it does. So you're going to see this a lot in rheumatology as well. So this is not the only place we're going to talk about methotrexate, but this is just the first. We use this all the time for our ALL patients. It's probably one of the more common ones that I run into on a daily basis when I'm working in the pharmacy. But it's also used typically in lower doses for rheumatologic conditions, right? And so the intent of the drug is also really important for how you're dosing it. So if I'm trying to kill off cancerous white cells, then I'm probably going to be giving a lot bigger doses in order to try to get rid of those cells. If I'm just trying to tamp down the immune system so that way the joints aren't being affected as much with like rheumatoid arthritis, then you're typically using lower doses. So the dose really matters here in terms of how likely you are to see some of these toxicities and how things are going to be dosed for these patients. So for instance, like if you have rheumatoid arthritis, you may be taking methotrexate every day or every week, sort of with no duration on it, versus for cancer treatment here, using much bigger doses, but typically on a very fixed schedule, like maybe once every 28 days or something, or whatever the regimen happens to be there. But what are these drugs doing? So instead of working to inhibit thymidylate synthase itself like 5-FU did, methotrexate is going to be working here on the reduction here of folic acid. So specifically it's inhibiting dihydrofolate reductase, and so it reduces these tetrahydrofolate stores. You can see here it's preventing dihydrofolate from being reduced down to tetrahydrofolate. And so basically, if you are missing these precursors, you cannot form new purines, right? You can't, thymidylate is not going to be formed here, and then you can't have thymidylate synthase work. So you could see how you could potentially use these two drugs together, methotrexate plus 5-FU, to get some synergy there, which may be done in certain regimens you'll see. Overall, though, the whole point is that you're going to get decreased DNA and RNA production in those cells, and that's going to help to kill off those cancer cells, right? This one you'll see all kinds of routes, orally, IV, and even intrathecally being administered to try to get any cancer cells that might be in the CNS. So these toxicities are pretty common and pretty specific for methotrexate. So this is the first one we're going to see kind of that differentiates itself from the other drugs we've looked at. This is also the first one we're looking at that has an antidote. And so I will tell you, and just like we did for the anticoagulant drugs, if there's an antidote available for a drug, you should probably know it, because one, I think it's important that you know how to prevent toxicity from drugs there's an antidote available because there's so few. That's good to know. Plus, I'm a tox guy, so this is kind of what I like to look at anyway. So I'll probably be more likely to ask questions about it. So again, there's an antidote for it. You should probably know it for the test and for future purposes as well. So anyway, so what are we expecting to see here? So folate antagonist methotrexate is going to be causing a lot of hepatotoxicity. Got to look at liver function tests, right? Certainly see the normal myelosuppression, GI toxicity, but definitely have to watch liver function tests. I remember my one of my aunts was diagnosed with breast cancer, and she was very sad because she does like her wine. And she unfortunately was diagnosed with breast cancer and was placed on methotrexate, and the doc said, you can't drink anymore. And so she's very bummed out about that. But, better than having breast cancer, I suppose. So, obviously lifestyle modifications are necessary for a lot of these drugs here to prevent, future toxicities. Renal toxicity is also really important here. This is very important for patients, especially getting really big doses like we would end up seeing in for cancer treatment specifically. And so this is basically due to the fact that methotrexate has a tendency, especially with more acidic urine or if it's particularly concentrated in the renal tubules, it can precipitate out. And so the precipitation of the drug causes little crystals to form, and that can cause actual interstitial damage because it's penetrating all these renal tubular cells. And so that's why it's really important to try to mitigate that as best we can. So I'll talk about that in just a moment here. Other interactions you're going to run into is the fact that methotrexate is highly protein bound to albumin. So if you have any drugs that come in and can displace it, that means you have a higher free fraction of methotrexate, and that can cause more toxicity. So another thing to note with that. And again, remember, these drugs are synergistic. So if I'm using something like cytarabine and methotrexate at the same time, they're both going to be inhibiting white cell production. They're both going to cause more significant myelosuppression. Better kill on the cancer cells, but also increasing your risk for infections for your patients, right? Now, antidotes. What can we do for people who either need recovery after getting a really big dose of methotrexate, or perhaps what can we do if patients have maybe gotten too big of a dose on accident, for instance, right? What do we do for them? A couple of things. First off, if we can't use folic acid because the dihydrofolate reductase is being inhibited by methotrexate, well, let's just give the active form of folic acid, and that is called folinic acid, otherwise known as leucovorin. And so this is sometimes called a leucovorin rescue that we'll give to patients. And so basically what we'll do is we'll give them a really big dose of methotrexate. We'll knock down all these cancer cells, healthy cells being affected as well, and then we'll give them folinic acid to help the healthy cells start to recover, okay? And again, it's working because it's bypassing that dihydrofolate reductase because it's already in the active form. The cells can use it even if that enzyme is being inhibited there. And so how we dose it is frequently determined by methotrexate levels. So if the levels are still high in the body after giving a big dose, we can continue giving that leucovorin for a certain period of time until levels drop down below a certain threshold, right? That's one way we can do it, right? If you were to give someone folic acid after getting methotrexate, it doesn't really do them a whole lot of good, okay? Now, you still may see some people who recommend folic acid, daily while they're on methotrexate. Again, it's kind of limited efficacy because those enzymes are being inhibited, essentially. Other things we can do for these patients, you can give them sodium bicarbonate, right? Sodium bicarb can be given IV, and that helps you alkalize the body. It helps to raise the pH of the blood, but more specifically, it also alkalizes the urine because you're filtering all that bicarb, and if the body detects that it's in a normal pH, 7.35 to 7.45, it's just going to get rid of that excess bicarb in the urine, right? So that alkalizes the urine, raises the pH up, maybe like, to 7.5 to 8 or something like that, and it helps keep methotrexate in solution, prevents it from being from precipitating out, helps you to pee it out faster. Okay, so again, it's very important when we're giving these big doses of methotrexate, we're also giving them sodium bicarb at the same time through their IV in order to make sure that occurs, right? So they prevent that precipitation. And then there's one last enzyme here we could use called glucarpidase, or Varaxase is the brand name. It actually is a direct metabolizer of methotrexate. So this is done sometimes if we have patients who we give a really big dose of methotrexate to, all of a sudden the renal function tanks for whatever reason, and they cannot clear that methotrexate. This is something we will give very rarely in order to help get rid of that drug in order directly to prevent any further toxicity. It's very, very expensive. I haven't seen the price on it last time. I might actually look that up while I'm still talking here. But quite expensive. And it's good for patients who have poor renal function, who cannot clear the drug itself. and they can go ahead and just cleave the methotrexate and just go ahead and get rid of it there. Okay, so very high levels, or if they have renal failure, that's what we're going to be doing. See here. You guys are probably like, I don't even care what this drug actually costs here. Yeah, so I'll just put this up on the just because I think it's important you guys sometimes know like what the implications are for giving some of these drugs here. Sometimes it can be quite the burden, as you'll see. Switching over here. So if you guys, I don't know if you can see that, but you can see it's $39,000, almost $40,000 for a single dose of this medication here, right? That's for 1,000 units, assuming that they don't need any more than that. So pretty wild, right? So again, it's a very expensive drug, so you have to make sure that we reach certain thresholds before we decide to give this. It's always a really big deal whenever we decide to give it because, again, where it's necessary, you want to give it, right? You don't want to hold something back because of it, just because it's expensive, but also you want to have a very high threshold to give it. Make sure you're not going to be giving it just willy-nilly to anyone, right? It depends. It's about, I think it depends on what we can potentially charge for it. There's a lot of negotiations going in the background to decide, because sometimes it's not like, you know, the healthcare provider's fault that the patient can't clear the drug. Sometimes the renal function just tanks for whatever reason, and then, you know, sometimes it is due to error, and then at that point they probably would not want to pay for it. Yeah, I'd probably rather buy a car than that. And typically it's expensive because, again, it's an enzyme that has to be produced. It's also a very niche drug, right? The number of people that may require this drug are extremely small, and so in order to recoup any sort of expenses, it's going to be expensive, right? Yeah. Anyway. Where it's needed, definitely needed. So those are the antimetabolite drugs there. Now we can move forward and talk about a different sort of mechanism entirely. And so these are going to be drugs that affect the microtubules, okay? Now microtubules, what do they do for us? Well, typically they provide the structure for the cytoskeleton of the cells, right? So they keep the cells sort of in a good structure, but they're also really important for mitosis. If you recall, back when your PMAT, so prophase, metaphase, anaphase, telophase, all that, towards the end there, when you have to pull, all the DNA is now lined up, all those chromosomes are lined up now in the middle of the cell, and you have to pull them apart in order to get their two constituent cells after mitosis. That is done through the microtubules. So we're going to see by preventing those microtubules from functioning, you cannot pull those chromosomes apart, and then you arrest mitosis, right? So you prevent it from, not like sending it to jail, but you're preventing it from going any further, okay? So very important from that standpoint. We will find that, again, if your cells are not actively undergoing mitosis, they're probably not going to be very effective because not a lot of those cells are in the M phase. But if they are actively dividing, then these drugs can be effective. And so we're going to have two set of drugs that fit into this category here, the taxanes and then the vinca alkaloids. So the taxanes here, and again, I always like to point out if things come from a natural source here. So this is the Pacific yew tree, not a me tree, but it's a yew tree. And so this is actually where the taxanes come from. So again, why these plants develop these compounds in the first place, who knows? But we found them, we identified them. Obviously, these are poisonous plants, so these are not things you'd want to eat if you ever saw these sort of little berries there. I don't know if they're berries technically, but I remember I've only ever seen these one time when I went to, got a trip to Ireland for an anniversary before we had children and before COVID, and yeah, things were better during those times. Let's just say it there. However, we saw some of these trees over there, and I had to tell my wife, "Don't eat those." She says, "Why would I eat those?" And I said, "I don't know, just don't eat them." She said, "Okay." Regardless, we have two drugs that fit into the taxane category here. So we have paclitaxel and docetaxel. And so basically what these drugs do is they help to promote microtubule formation, but then they prevent the breakdown, okay? So you have the microtubules form, but then they can't actually be broken down, and so they kind of prevent the mitosis from finishing up its steps there. So it kind of prevents the functional end of mitosis. In terms of toxicities here, and actually there's a document I need to put up on the site, which I'll do after today. It's going to be, his name is Chemo Man, is a picture of common side effects associated with chemotherapy drugs. You can Google it if you like, or anti-neoplastic man might be another term for him, but I'll put a picture of him up. I guess he's probably gender neutral, if anything. So anti-neoplastic person, I will say. So I'll post that up so you can see a sort of pictorial example of common anti-neoplastic side effects, which are important to know for the test. So obviously with this, myelosuppression is going to be seen here both, but in terms of specific toxicities here, these are unique. So like docetaxel, you can't see fluid retention. So it might not be great if you have someone, for instance, with CHF that holds on to fluid anyway. And then with paclitaxel, we can see peripheral neuropathies that can develop here, usually in that stocking glove sort of distribution. So that's kind of a unique thing there. And then hypersensitivity can be fairly common with these drugs as well. And so frequently they do require pre-treatment to prevent some of those side effects. So if you ever see patients who are getting like Benadryl, like a diphenhydramine or another H1 blocker, plus a corticosteroid like dexamethasone prior to getting one of these drugs, some of that is being done to mitigate those hypersensitivity reactions, prevent rash and itching, and maybe even potentially anaphylaxis in some rare cases. On the other side, let's see, Isabel said, would you want to avoid this in diabetics due to peripheral neuropathies? That depends. And again, I don't do a lot of adult cancer treatment, so they may have something different to say in those cases there. I only see it on the pediatric side where type 2 diabetes is fortunately pretty rare. But that is something you'd want to know about. You'd want to know what their current state is, if they have any peripheral neuropathies, and be able to track it to see if it's getting better or worse, right? Obviously, anything new onset is going to be pretty concerning, but if it's getting worse, then you'd also want to know about that as well. Very good question. So we had the taxanes that are promoting production of the microtubules but preventing the breakdown. This is sort of doing the opposite side, and this is the vinca alkaloids here, and this is actually an example of a periwinkle plant. And so again, another common source there. And so from these plants, we get things like vincristine, vinblastine, and then venerelbine. Vincristine is probably the most common one I deal with on a day-to-day basis here. These basically prevent the formation of the microtubules. So kind of working on the opposite end, they're preventing them from actually being formed in the first place. If you can't form the microtubules, then you can't undergo mitosis there. Now, these ones are pretty interesting because these are fatal if given intrathecally. I cannot stress this enough, so this is really important. And you're like, well, how would I accidentally give a drug intrathecally? I'm going to underline it and italicize and everything. You're like, well, how would this accidentally happen? Well, the reason why I'm making such a big deal about it is because obviously someone has accidentally done it and caused fatality to occur there. So imagine a scenario where you have a patient, say you're the PA working on the oncology unit, you have a patient who's getting both intrathecal methotrexate and then vincristine IV at the same time. If you are giving two medications very close to one another, it is possible that you could accidentally get them mixed up, right? Even though there's labels on medications typically. Sometimes people don't read the labels. I've had very world-renowned physicians who don't read labels, right? So again, human nature is prone to error, as it turns out. And so if you were to screw this up and mix it up and give the vincristine intrathecally, that you will kill that patient, right? So that's why we do certain safety features here. So for instance, we try to, or we only put vincristine into like an IV bag. We never put it into a syringe because syringes would be the only thing you'd hook up to give something intrathecally, right? We put labels on everything that says fatal if given intrathecally. Again, if you see a big warning in a hospital for something that seems like really common sense and like, why would you need a warning for that? It's because someone did that thing, right? So this is really important if you're working in chemotherapy or working with oncology to prevent this, okay? Other things, extreme myelosuppression. Again, these are things that are going to be count dependent. So you want to make sure that they have good neutrophil counts, make sure that their platelet counts are looking good prior to administering. And then vincristine also has that hand-foot sort of neurotoxicity. So this is another big one you want to be watching out for that. And also uniquely can cause this paralytic ileus and constipation. So I've actually had a few patients who could not receive any more vincristine because they had such bad constipation associated with this. So not just the peripheral nerves being affected, but actually even the GI tract can be affected as well with vincristine, right? And again, I'm not worried about you guys getting vincristine mixed up with a VCR because most of you probably never had a VCR growing up, so I don't have to worry about that. Isabel's saying, would you want to avoid this? I'm sorry. Kelly was asking, so does this apply to all three of those drugs or vincristine specifically? The constipation paralytic ileus is going to be more specific to vincristine along with the neuropathies. You may be able to see that a little bit with vinblastine, but it's more specific to vincristine. And again, vincristine is the most common one I end up seeing used clinically. Not sure if that's the same in adults or not. Now, the other unique thing about this too, and I'll bring this up for a few drugs, these are vesicants, okay? Oh, for the intrathecal fatality, that is all three of those. Okay, yeah, so that's important for all three of them. Thank you for clarifying that. And before the time on VCR, I also used to watch the same thing, so perhaps we're I'm just barely a millennial. Some of you are probably already in the Zoomer generation though. But anyway, so looking at vesicants, what that basically means is if you have a drug that is accidentally infused into subcutaneous tissue, it's going to cause tissue necrosis, tissue breakdown, tissue injury, right? So you're like, well, why would that ever happen, right? So basically what happens if you have something called extravasation, where you have a line in place, say it's a peripheral line in the arm, for whatever reason that line blows, right? The vein ruptures, someone accidentally gets the IV set up outside of the vein, and then you infuse the drug. That's where you get this subcutaneous administration of the drug that it can cause significant tissue injury. That's called vesiccation. We have a lot of protocols in place to prevent that from happening. So for some drugs, you want to apply heat to it because that will allow for the drug to be absorbed a little bit faster. Some drugs you want to apply cold to it. There's certain antidotes we'll give. I'm not going to get into the details of that, but know which ones are strong vesicants because that can cause significant injury and harm to your patient. And there's been cases of amputations as a result of this before, so it's something you want to be aware of. As I was saying, worst was getting a VHS at Blockbuster. It wasn't rewound. Oh, it's terrible. I used to have like a little car that you'd put in and that would rewind your tapes, and it had like lights on it. It was pretty sweet. So, not to brag or anything. Anyway, so again, just to give you an idea of where these drugs are working at, so you can again see they have different targets here in the microtubules. There's actually another drug we're going to be talking about later on when we get to talking about gout called colchicine. It actually works kind of on a very similar target here as well. So again, just know that the taxanes are going to be working on preventing breakdown of microtubules. The vinca alkaloids are working on preventing the formation of microtubules, but ultimately they get the same action done there, preventing mitosis. All right. So next up, if we're trying to find sort of analogs between antibiotics to chemotherapy drugs, we can see here that now we have something that's very similar to the fluoroquinolones, okay? So we also have topoisomerase, just like bacteria do. And so if we can try to prevent topoisomerase from working to cause those single and double strand breaks, you prevent the DNA from relaxing and prevent it from winding itself back up. And again, that leads to further DNA damage, strain breaks the cell does not like, and so eventually you can trigger off apoptosis, okay? Now, some of these drugs are going to be working for topoisomerase 1. Some of these are going to be working for topoisomerase 2. I don't care which ones you know there. It should be working. Just know that if it works on topoisomerase or not. Yeah, sorry if you're having any issue. That's strange. I don't know why I'm getting so many issues today. Anyway. So maybe reload or something. But so again, very similar mechanism to the fluoroquinolones. You can just think about those as being pretty synonymous. We have 3 groups of drugs here. We have the epidophylotoxins. Say that 3 times fast. We have the anthracyclines and the canthothecans. Okay. Yeah, everything looks good on my end. So I'm not sure what's going on with you guys' internets. Maybe the tubes are clogged up or something. So starting off with the epidophylotoxins, here we have etoposide and tenipicide. These, again, are going to be working to some degree, they actually work on the microtubule formation, but the primary function here is to inhibit topoisomerase 2. So it actually prevents, again, the unwinding and the rewinding of the DNA, and it induces strand breaks, which again can hopefully trigger off apoptosis if there's enough damage being done there. This is coming from a plant as well. I think this is the May apple, if I recall correctly. You actually get the epidophylotoxins. I'm not going to ask you specifically on the test which one of these comes from the periwinkle plant. I don't really care to know that. I just think it's interesting. But again, here in terms of toxicity, dose-limiting myelosuppression, nausea, vomiting, alopecia, pretty common with this class of drugs here. Next, we have the anthracyclines. This is actually a pretty unique one in terms of its mechanism because it actually has sort of a structural sort of attack that it has, which is neat. But we have 3 drugs here. We have doxorubicin, daunorubicin, and then mitoxantrone. These are all considered to be anthracyclines here. If you notice, if you ever see like a bag of red IV fluid hanging, it's probably something like daunorubicin there. It actually looks like wine or something when you see it hanging. It has a very particular color to it. But basically what this drug does is that it can inhibit topoisomerase 2, which is important, but also does something called intercalates into the DNA. And I think intercalate is probably one of my favorite words in the world because basically what it does is it can like jam itself. And if you look here, it's kind of a planar structure. See here, it actually jams itself in between the strands of the DNA and prevents enough structural integrity issues that can again lead to further damage. And not only that, but also produces free radicals, which causes oxidative damage done to the DNA as well. So no, again, we're just trying to induce enough damage to cause apoptosis to sort of take over there. I think I've seen a few IV administrations of alcohol, and it's not great. So I probably wouldn't recommend that. Maybe if it was like 98% pure ethanol, that we've done that before for like radiator fluid ingestions, but wine might be a little rough on the veins there. But you're sure to try it out and tell me how it goes. Don't inject wine into yourself. Anyway, so toxicity here is going to be important. Yes, definitely. I like when they can incorporate scrubbed references as well. So with anthracyclines, you will see certainly a lot of myelosuppression, but this is a really unique one to the set of drugs here: cardiomyopathy and CHF. In fact, the free radical production that it causes there is particularly toxic to myocytes. Myocytes themselves don't have a lot of ability to detoxify those free radicals. They don't have a lot of antioxidants there in order to help mitigate that. And so actually what's really interesting is that there's a lifetime max dose that a patient can receive. So once they've hit that maxed lifetime dose, they can never get it again in their entire lives, okay? This is kind of the first time I've ever seen a drug actually be able to do that, where they say, nope, can't get any more, you've hit the limit, right? And not only that, we have to make sure you're doing echoes at baseline and then following up to make sure to see any changes that are there, because if you start to see any significant decreases in EF, for instance, you probably want to discontinue the drug because, again, toxicity is going to be too much at that point. Not only that, but you can see red discoloration of the urine and the sweat, and that can actually have some problems in terms of some of your labs as well. Some of your labs are going to be colorimetric, meaning they look for color, and so if you have additional red stuff floating around the blood, that can actually affect some of your lab values too, which is kind of interesting. And these are also really strong vesicants, just like the vinca alkaloids. So you want to make sure you have a good IV in place. A lot of these patients will probably have some sort of implantable port. That way IV access is pretty well taken care of in a more semi-permanent way. Some patients have central lines help to mitigate this, but again, be very aware of. So you start to notice pain, patients complaining of pain in the arm, wherever's being infused, that may be signs you need to stop that medication right away because that tissue damage can be significant. One drug we do have here in terms of an antidote is called dexrazoxane or Zenocard. This is actually something that's a chelator that actually chelates iron. And so iron is actually really important for a lot of the free radical generation that occurs. And so by chelating that iron, you can prevent some of the cardiotoxicity that happens here. So we consider that to be a cardioprotective agent, right? But it doesn't mitigate any of the other stuff. It's really just trying to stave off that cardiomyopathy from developing for those patients. All right. And then we have the camptothecans. This includes topotecan and then irinotecan. These ones here, they're going to be inhibiting topoisomerase again, just like we saw. And then we'll have significant myelosuppression. Now, what's interesting with these drugs, kind of the unique thing with this, is that the diarrhea that can be induced with this is pretty significant. And it actually does that. It's kind of more seen with irinotecan than topotecan, is due to it decreasing cholinesterase activity. And so diarrhea makes sense if you know the mechanism there. So by decreasing cholinesterase activity, I'm not metabolizing acetylcholinesterase as well, so those levels are higher. And so that means that acetylcholine levels are higher. They're able to act on the muscarinic receptors on the GI tract, and then you get profuse diarrhea. So again, you do want to be careful there because, one, that can cause issues of fluids, right? So it can cause dehydration to occur there, acid-base disturbances, all kinds of things. So do want to be cautious there. Frequently, we're going to give drugs that slow down the GI tract. So we'll talk about this in GI next semester, but things like loperamide and things like that try to slow down the GI tract to mitigate some of this toxicity here. All right. So we talked about our antimetabolites. We talked about our drugs that work on topoisomerase and the microtubules and all that. Now we're getting into our alkylating agents here. And so this is kind of an interesting class of drugs. They've been around for pretty much forever. And in fact, I think I took this off the slide here, but if you ever read like the pharmacy Bible, quote unquote, it's called Goodman and Gilman's. Those are two long dead pharmacists, but they actually worked to sort of establish kind of the first major textbook for pharmacology, but they worked with some of these agents here. Now, if you notice, I have this picture here and it says, talking about mustard gas, and it smells like garlic. This used to be like, this is the basis for some of the early chemical warfare agents that we had there. So it's actually kind of interesting. And in fact, it was mustard gas that was used in World War I is sort of a precursor to a lot of the alkylating agents that we have nowadays. So obviously it's a war crime to use stuff like that, but we can use it therapeutically in order to treat some patients' cancer. But as you might imagine, if it was used to kill people in war, it's also pretty toxic to us as well. And so in general, alkylating agents tend to be some of the worst offenders in terms of causing myelosuppression, in terms of causing nausea, vomiting, a lot of things. We'll get into that in more details here going forward. Anyway, so what was interesting though is they actually found that a lot of people who were exposed to mustard gas during World War I developed significant myelosuppression after being exposed to it. And so they're like, well, wait a second, that seems kind of interesting. What if we could use this for clinical effects there? And so what they realized that it does, it actually will cause covalent bonds to occur between alkyl groups in the DNA. And so this causes strand deformation to occur. It either occurs within the strand itself or between the two different DNA strands there. And the nice thing about this is it affects cells no matter what cycle they're in. Whether they're actively growing or not, whether they're producing DNA or not, it just affects all of them because it directly targets that DNA. That also means that it's going to be affecting a lot of our healthy cells as well. So again, a lot of toxicity seen with these. They are cytotoxic, meaning they're going to kill healthy and cancer cells. They're mutagenic, meaning they can cause DNA mutations to occur, which means they can lead to further cancers, right? You think mutagenic, you're like, cool, I'm going to get like, I don't know, regenerative powers or maybe laser beams out of my eyes, but nope, it's just cancer, unfortunately. They can also be very teratogenic, so you want to make sure patients are not pregnant while they're receiving these, and they're very myelosuppressive. Okay, and then in general, they can also cause pulmonary fibrosis. So again, pulmonary function tests are very important to monitor for as well, right? So first off here are going to be their nitrogen mustards. And again, there are very few hot dogs I would probably want to put nitrogen mustards onto. Probably does not taste very good. But a few that we have in this category includes cyclophosphamide and then ifosfamide. And so these are used to treat all types of cancers, hematologic, solid tumors, a wide variety of things that they're effective for because, again, they affect, their cell cycle non-specific. They work on fast-growing cells, slow-growing cells. They work on everything. Okay. So in terms of their specific toxicities here, and again, you can see some of the actual bonds that are occurring here. So if you notice how something like cyclophosphamide could actually go in and actually cause covalent bonds here between the various nucleotides here, it's like the cross-link that happens here. Well, things like DNA polymerase just can't work on that anymore because it's being blocked up by the nitrogen mustard, essentially. But let's talk about some toxicities here for these drugs specifically. So these actually form a toxic metabolite called acrolein, and this is actually leading to hemorrhagic cystitis, right? So you definitely want to be monitoring your analysis and whatnot for this. This can be mitigated by giving a product called Mesna. I'm trying to think of the generic or the chemical name off the top of my head, but it eludes me currently. But basically, we give Mesna along with cyclophosphamide and then ifosfamide to try to prevent the hemorrhagic cystitis. That's the specific thing that is trying to prevent there. Other toxicities you run into can be altered mental status and encephalopathy that can occur here. This is a little more frequent with ifosfamide, but certainly you want to be monitoring for any sort of CNS changes there. They can also cause renal toxicity, and then certainly you're going to see this to be pretty ubiquitous amongst most of the alkylating agents of myelosuppression, alopecia, and nausea, vomiting. Okay. The metagenic potential of these drugs, right? So how likely they are to cause nausea, vomiting, tend to be the highest with the alkylating agents. Okay. So I will be talking about that a little bit later on. We talk about emetogenic potential. I tend to have a very high emetogenic potential as well for most of my tests, as you've probably no doubt noticed. Also, other things we can do to try to prevent that hemorrhagic cystitis from occurring tends to be very vigorous hydration. So it's not uncommon to be giving patients liters of fluid through their IV at a constant rate in order to make sure you're flushing out the kidneys and getting rid of any of this stuff, or flushing out the bladder in this case here, try to get rid of the drug to prevent the acrolein from causing cystitis. Next, we have the nitrosoureas. This includes carmustine and lomustine. This one's actually kind of interesting. It's actually used in many brain cancers due to its lipophilicity and able to actually cross the blood-brain barrier. This is a case here where it's actually being used to treat a brain tumor. There's actually videos of this you can go check out, which I find fascinating. But you can see here, there's carmustine that comes in this little wafer. And again, this is probably not a wafer you'd want to ingest by any means. But basically what is happening here is that a surgeon has gone in and actually removed a brain tumor. And then they put in these wafers that kind of lines all the surrounding areas there. And you're like, well, why would they do that? Well, because the provider probably doesn't know if they actually got every single one of those cancerous cells there. So by providing the drug here locally, they can then slowly release the drug and be able to get any cancer cells that might be left behind there. So kind of by getting good coverage and covering all of the tissue, you're able to get as many of those cancer cells as possible, and they can go in later on and then remove those. This is also did something like that. Patients on Grey's Anatomy. Interesting. Yeah, I haven't seen that show, but I can imagine they did something. Might have come up. Yeah. This is also really interesting. So the myelosuppression that these drugs, these two in particular, can cause can be very significant, right? We've seen myelosuppression for almost all of these, but this, not all of them are created equal in terms of how significant of myelosuppression you'll see. And so, for instance, these can actually be used to prep someone for bone marrow transplant. So if you want to wipe out all of someone's bone marrow to get them ready to receive a transplant, then this may be something you would do to help prep them for that. So again, very significant myelosuppression here. And not only that, but you can actually find that the nadir can be quite delayed, right? So the nadir being the lowest point that their white cells are going to be hitting prior to them starting to recover, right? So what's the lowest trough that they really hit before they recover? And so for most of these, you think your white cells are pretty fast growing, that you should be able to see some changes pretty frequent or pretty quickly. But here you can actually find that it is delayed up to 4 to 6 weeks and can last up to 2 weeks, meaning your patient could be really at big risk down the line, like a month from now, of developing these secondary infections there. So again, really, really important to watch out for that. And again, can be fatal if their immune system is completely wiped out and they can't fight off anything, right? All right. So next up, these are drugs that are good if you have patients that have excellent insurance. These are the platinum analogs. We only reserve it for our VIP patients. I'm just kidding. All of our patients are VIPs. These are just drugs that actually include platinum ion here. So we have things called cisplatin, we have carboplatin, and then oxaliplatin. You can tell it's a platinum analog because it has plat in the name there. And again, these are going to have the same mechanism as the other ones. They can cause both interstrand crosslinks to form here covalently. They cause interstrand bindings to occur here. Again, very, very toxic, very likely to cause a lot of severe nausea, vomiting for these patients here. But again, the mechanism is identical to all these alkylating agents here. Are platinum analogs still considered alkylating? Is this another category? No, these are all alkylating agents we're talking about. So from the nitrogen mustards till now, and even I think we have some more, these are all alkylating agents. And you can see that right here. You can actually see the actual alkylating that they're doing by binding to the actual DNA strands themselves. This is another one that also can lead to nephro and ototoxicity, so you do want to watch out for that. Again, if you can flush the kidneys out with a lot of fluid, a lot of crystalloid fluid, that can be helpful to mitigate that, but you do have to watch out for the hearing and make sure that's not changing over time. Also, they can cause peripheral neuropathies, just like we would see with something like the vinca alkaloids, and hypersensitivity is a possibility. It's low, but it can still happen here. But the severe nausea vomiting is really important. These are probably some of the most emetogenic drugs that we give to patients, and so we'll look at some ways we can try to prevent that down the line here. A couple other alkylators run into things like dacarbazine, temozolomide, again, working through very similar mechanisms what we'd see. These not only even bind to DNA, but also to RNA, and by doing that, they can actually affect protein synthesis as well. Again, toxicity is pretty similar to what we saw before. Busulfan's kind of interesting. This is one that works pretty similar to the nitrogen mustards. This one is actually really well known for pulmonary fibrosis. So it can happen with any of the alkylators, but this tends to be more common with busulfan. They often talk about like busulfan lung that can develop over time. You do have to watch out for that. Make sure you're doing your PFTs to make sure that that is not heading in the wrong direction there. Again, seizures are also a possibility here, which is sort of unique to these drugs. So if that is seizure disorder beforehand, this may not be the set of drugs you want to administer to them. All right. Then moving on. So that's the end of the alkylating agents there. Let's look at some of our miscellaneous drugs. It's probably cutting out for some of you guys, and I apologize, but I cannot control YouTube. All right. So some other things we can do. So we can try hormonal therapies. They can actually be pretty powerful in terms of helping to curtail cancerous growth from being stimulated. Because if you think about what hormones do, I mean, they can stimulate growth of certain cells, or they may inhibit growth of certain cells, as the case may be here. So for instance, we can use things like androgens and estrogens that themselves may either be stimulatory on growth of cancer. So for instance, things like testosterone and dihydrotestosterone stimulate growth of the prostate, right? Which can lead to things like BPH, but then on the negative side, it can lead to prostate cancer actually forming there. Things like estrogen can influence breast cancer growth and endometrial cancer growth there. So when we're introducing drugs that try to affect these systems here, we're typically trying to antagonize those receptors. Or if we can prevent the production of sex hormones, that can also be quite effective there. So if I can give something that prevents DHT, which is dihydrotestosterone, which is a more active form of testosterone from being formed, then that can be good. And I'll show you some examples of that. In terms of corticosteroids here, this is where we're thinking about things typically like dexamethasone, prednisone. These are typically useful for lymphotoxic cancer, so things like leukemias. It kind of makes sense because if you think about what the corticosteroids do to your immune cells in the first place, they inhibit their growth, right? These are immunosuppressive drugs. Well, they can do that same thing for leukemias as well. They suppress those cancerous white cells. So that can be useful. These are also pretty handy for chemo-induced nausea and vomiting. So sometimes you get a little bit of a dual mechanism there. They're helpful for the cancer, but they can also be used to treat nausea and vomiting. They actually help to suppress the chemoreceptor trigger zone to some degree. So again, we'll look at some examples of that in a little bit. So as I mentioned, with steroid hormones, they typically bind to somewhere in the DNA that is responsive to them, so that can influence growth of these proteins and whatnot, or change transcription factors and whatnot. So again, if we can try to inhibit those hormones from interacting with those targets, then that can be very beneficial to stave off growth of those cancerous cells there, right? So some people may be more likely to express certain hormone receptive elements. Some people may be less likely depending on their own individual sort of genetics there. And so, hormonal therapy, tumor growth is really going to be dictated by a lot of the influence of those hormones, as we mentioned there. So, as I mentioned, glucocorticoids, you can suppress white cell production by administering those, or with using anti-estrogens or anti-androgens, these can be specifically used for those types of cancers that are responsive to them. So with anti-estrogens, you probably use like in breast cancer or uterine cancer, versus anti-androgens, more likely to be seen in testicular and prostate cancer. So just a few examples of these. Some of these we'll talk about more specifically in the endocrine section next semester, but just to touch on them here to show you some examples of how these work. So for instance, with tamoxifen, this is what we call a selective estrogen receptor modulator, or a SERM, if you ever hear that term. This is a partial estrogen agonist, and so this actually can compete for estrogen at the same site. And so this can be useful for estrogen-dependent breast tumors. That way, instead of shutting down all estrogen production in a woman's body, because that can have some significant side effects, if we can try to antagonize just the estrogen effect at the breast tissue, then that can be preventative of developing further breast cancer cells, right, or further causing the replication to occur there. And so this can even be used in some patients who are really high risk based on family history to try to prevent them from ever developing cancer in the first place there. Now, the toxicities, as you might imagine, depend on sort of where it's acting like an estrogen at, and where it's acting as an antagonist at. That's kind of the unique thing about tamoxifen. For some tissues, it's going to act as an agonist, and for other tissues, it's going to act as an antagonist. Okay, so in the breast tissue, it's working as an antagonist, preventing those breast cells from further replicating. You're also going to be causing a lot of systemic effects that may mimic what happens when women normally lack estrogen. So for instance, things like hot flashes and nausea, vomiting associated with that. However, you can also see, like on the liver, for instance, it acts as an agonist, so you can see things like DVTs develop here, pulmonary embolism, right? So it's kind of a mixed bag depending on where it's acting as an agonist at versus an antagonist. And also, because it works as an agonist at the endometrial tissue, it can lead to endometrial cancer, right? So this may be something where tamoxifen is good for patients who may have breast cancer, but they've had a hysterectomy. They don't have any endometrial tissue left to stimulate, for instance, okay? Just as an example. And we'll see this also has positive effects on the bone and for your cholesterol. So that can be a good thing too if patients have osteoporosis, for instance. So again, a lot of it's very dependent on sort of patient status, what they're responsive to, what they're not responsive to, etc. See if this drug would actually be good for them or not.
Now, raloxifene is kind of interesting because this will have estrogen effects in the bone and the cardiovascular system, but it's an antagonist of the breast and uterine tissue. So while some of the side effects may be similar between tamoxifen and then raloxifene, it actually can have less or no endometrial cancer risk because it is an antagonist of the uterine, right? Uterine tissue. This one you may see a little bit more often used in patients with osteoporosis because, again, it has good effects on the bone, but it's not going to stimulate breast tissue development, which can lead to breast cancer for some women there. So, again, very, very selective depending on the type of patient that you're working with. Now, another way we could do this would be with something like a selective estrogen receptor downregulator. So, actually, by downregulating the number of receptors available, the estrogen that's there can't interact with those receptors and thus not stimulate that tissue there. So, this is a pure anti-estrogen sort of drug overall. So, you're going to be able to see systemically, hot flashes, osteoporosis risk, and things like that. So some of these drugs are better as sort of backup agents if the initial ones have failed. So if like they failed tamoxifen therapy, maybe do something like fulvestrant, for example. It really just depends on the situation there. Or if we can do things like decreasing the actual estrogen production itself. So sometimes these are also used as sort of second or third line agents when something like tamoxifen has failed. These are aromatase inhibitors. So aromatase is an enzyme responsible for converting testosterone over into estrogen. And so if I inhibit that enzyme, then you get less estrogen actually being formed there. Because again, testosterone is a precursor to estrogen. And so what you can actually see here is if they have failed agents like raloxifene or tamoxifen, you can utilize this to overall reduce estrogen levels in the body and thus get less stimulation on that tissue there. Obviously, things like hot flashes, some masculinizing effects can occur because you're getting more testosterone levels. All that are pretty common with these set of drugs here, anastrozole and then letrozole. Then we have a exemestane, which is an irreversible inhibitor. So as opposed to these being competitive reversible inhibitors, this is even stronger on that. And basically you get estrogen levels down about 90% or so. So it's very easy to induce a lot of menopause-like symptoms because the estrogen levels just plummet with this. But again, it's good for backup in case patients have failed other things, right? So balancing the symptoms of menopause versus the cancer risk is really important for some of these patients here, and especially if you're thinking about risk of things like fractures and all of that. It's a very fine balance you have to be sort of walking the line between. Here's an example of a few anti-androgen drugs you'd use for things like prostate cancer, for instance, or maybe testicular cancer. There's like flutamide, nilutamide, and bicalutamide. And these actually bind to the androgen receptors and prevent testosterone from interacting with them. And sometimes we'll actually give it with a few other drugs here, which I think I'll talk about in just a second here, called leuprolide and gozerelin. As you might imagine, though, by blocking testosterone activity, you're going to get a shift in balance over towards more estrogen-like effects there, which can be things like gynecomastia, for instance. Here's an example of leuprolide and gozerelin. These are actually analogs of GnRH, which is gonadotropin-releasing hormone. These are kind of interesting because depending on how they're used, they can either stimulate production of LH and FSH, or they can actually shut it down completely. I'll talk more about this next semester, but I'm just trying to give you ideas of different ways we can modify the system a little bit. As you can see here, if you're giving enough to shut down production of FSH and LH, which normally stimulate testosterone and estrogen production, as you might imagine, these levels of testosterone and estrogen are going to drop pretty substantially. And so here you can see things like impotence can develop, gynecomastia, hot flashes. Really just depends on the patient and what their sort of existing hormone levels are and how leuprolide or gozerelin are going to be interacting with that. So, I think I only have a couple minutes left here. I want to see how many questions I have. I got a couple questions here, so I'm going to mention those before I let you guys go. Let's see, we got about 30-ish slides left. I think I'll have enough time to cover that, and then we'll go ahead and then do the review next time. So I think that'll be Wednesday. So just sit tight. We'll finish this up and then do the review, and then you should be good to go for Monday. I reviewed the test already, and I think it looks pretty good. You guys may differ in your opinion, but that's okay. And we'll go from there. But let me switch over. Looking at the sticky board here. So someone said, for RX assignment number 3, do we need to write out that list of drugs that it says to give with like the combination? Oh, so I think you're talking about the mercaptopurine one. No, you don't have to put the other drugs on there. So that's an example of something. So that was mercaptopurine, I believe. instead of being used in combination with the regimen like vincristine and some other stuff. So that would be a situation where a patient would, for instance, and you can kind of see that if we go back to the PowerPoint here, if we look back at that, apologize, this is probably like wigging at your screen at all. So if you go back here, this would be a case for someone like that where they would be getting multiple drugs at the same time. They would come into the infusion center to get like cyclophosphamide ARC, but then they would be receiving mercaptopurine every day at home, right? So this is a case there where they may not be prescribed all of those drugs. Some of them would just be given in the infusion center or inpatient while they're taking the other one here at home, for instance. So you don't have to write for the other drugs, just write for the one mercaptopurine prescription that I put there. So then someone says, would you like us to know specifically if a drug acts on topoisomerase 1 or 2? Nope, I just want you to know if it works on topoisomerase. As much detail as I want you guys to get into. So as far as antidotes, would glucarpidase be something that you would give in a more emergent situation since it directly gets rid of methotrexate, or folinic acid, sodium bicarb work as well? So that depends on the situation. So typically what you'll find, depending on the regimen and sort of the dose that patients are getting, sodium bicarb is, if it's a relatively low dose, you may not do any of those three, right? For like, say, a really large dose that we're administering, say they're getting like grams and grams of methotrexate. I've seen cases where people are getting like 80 or 100 grams, right? So quite a bit of methotrexate. That's a case there where we would infuse the drug along with sodium bicarb, give those two together because that prevents the methotrexate from precipitating out in the kidneys as the drug is in the system. And then after the methotrexate is done, then we would follow it up with the folinic acid to try to help save any healthy cells that we can. Okay. Now, can some of those cancer cells also use that folinic acid? Yes, but again, you're taking the good with the bad in those cases there. You got to save the patient because if the patient dies, yeah, you kill the cancer, we got rid of the cancer, but the patient died. It's kind of a solid victory there, right? Anyway, and then the glucarpidase is, yes, that is more for those emergent situations. So if we see a patient who got like a big dose of methotrexate and then maybe we didn't give them enough bicarb, or for whatever reason their kidney function tanks, they are not clearing the methotrexate, that's where we have to consider giving the glucarpidase, right? So it's a very few and far between. I think I've seen one case. I think I've been at Nemours for 8 years now, and I think I've seen like 1 or 2 cases of it ever being given. So it's quite rare because, again, it is quite expensive. We would like to prevent that by giving things like bicarb and folinic acid beforehand in order to prevent that. I think I've seen a few methotrexate overdoses, usually accidental, through the poison center. Most of the time we get by just using sodium bicarb and folinic acid. I've never personally recommended glucarpidase. That's going to be probably more done on the oncology side of things than anything else. So hopefully it gives you a little bit of context for how we'd use that. All right, so any other questions from you all? I apologize if there's any streaming issues for you, but again, it's recorded, so you can always go back and check out anything you missed, obviously. Otherwise, I will see you guys all at 12:30 for our journal club. The article is posted there. They'll be on Zoom, and then we'll meet again on Zoom on Wednesday for our review for the test. If you have any questions in the meantime, let me know. Otherwise, I guess I'll see you guys all then. Thank you for joining me, and I'll see you then next time. Thank you all.